regarding the ear, we had discussed the anatomy and physiology, the basic things. And then regarding the diseases, we discussed regarding the diseases of external ear and middle ear. So the leftover is inner ear. So here we are going to discuss regarding the diseases of inner ear. Okay. In case of inner ear, there are three diseases most important which has to be discussed. Those were one you all might be knowing regarding it, that is Meniere's disease. Then comes acoustic neuroma. Then comes glomus jugular or tympanicum tumors. So these three conditions only we will be discussing in case of inner ear diseases. So let's start with Meniere's disease. So first let's start with the other names of Meniere's disease. They were endolymphatic hydrops. Endolymphatic hydrops. Then glaucoma of ear. Then epileptiform cerebral congestion. So these are all the other names of Meniere's disease. So one is endolymphatic hydrops, then glaucoma of ear, and epileptiform cerebral congestion. So let's see the exact pathology, what is leading to this condition. With the other names you might have guessed. So here in the first name it is endolymphatic hydrops. So something related to the endolymph. Hydrops is nothing but the collection of fluid. So there is some collection of fluid in the endolymphatic system. And glaucoma, you all know, there will be glaucoma of eye is none other than the rise in intraocular pressure. And the same way in ear also there is rise in pressure because of collection of fluid. Or here epileptiform cerebral congestion, this is also indicating some type of stagnation. So let's see the exact pathology. So here the pathology is there will be distension. In the inner ear, you might remember the endolymphatic sacs, bony labyrinth, membranous labyrinth. I think in previous classes we had discussed. So here what happens? There will be distension in the endolymphatic system because of the rise in endolymph volume. This lymph volume gets increased. So because of that there will be distension. And why this endolymph is increasing? It's because of the faulty absorption. Either faulty absorption or overproduction of endolymph leading to the increase in the volume and leading to the distension of endolymphatic system. So this is the exact pathology behind it. So clinically, what are the things we can notice? First, clinically, how the patient will be presenting, what are all the things we can notice. So first it is unilateral. Most commonly it is of unilateral in origin usually, and then comes the symptoms. Episodic vertigo. So here this is the first symptom to appear. First comes episodic vertigo, then comes fluctuating sensory neural deafness. Then comes sensory neural deafness, and then tinnitus, sound in the ear, ringing sound. Then oral fullness, feeling of fullness in the ear. So these are all the key symptoms of Meniere's disease, and in case of our materia medica, there is one specific drug related to Meniere's disease, that is chininum. Sorry, mistake. Chininum sulf can be referred for Meniere's disease. So here in case of clinical, there will be unilateral, and there will be episodic vertigo, which is the first symptom, then fluctuating sensory neural deafness, tinnitus, and oral fullness. So these are all the symptoms mainly we can see in case of Meniere's disease, and adding to that there will be diploacusis. This is new for you. Diploacusis, and it is none other than the same sound which will be pursued as different pitch in 2 years, because 1 year is only affected. So different pitch in 2 years. So this is called as diploacusis. So hearing 1 year will be receiving in some pattern, and another year will be receiving in some other pattern. So this is called as diploacusis. Next, followed by there will be intolerance to loud sound. They cannot hear loud sound also. So because if they cannot hear the loud sound, they are becoming poor candidates for hearing aid. Even if we place the hearing aid, they cannot tolerate that also. Okay. Hearing aid cannot be used in such patients. Next, there are two, one sign and one phenomena which is related to this disease. First one is Hennerbet sign. Hennerbet sign. So here, regarding Hennerbet sign, whenever there is induced excursion, pressure will be placed on stapedial fluid plate. Induced exertion of stapedial foot plate leads to vertigo and nystagmus. Okay. So whenever there is any pressure in the stapedial foot plate, that may lead to vertigo and nystagmus. It is called as Hennerbert sign, and it is also called as false positive fistula test. Okay. This test is more important. In case of fistula test, there are various results, and this Hennerbert sign is a false positive fistula test where after the induced exertion, that is pressure on the stapedial foot plate, leads to the vertigo and nystagmus. Then at last, Tullio's phenomenon, which is related to this disease. So here what happens? There will be loud noise, and this loud noise leads to vertigo. Why it is occurring? It is because of the distended saccule. So whenever there is noise, there will be movement of vesicles. So what happens? This saccule is connected with the foot plate of stapedis. Surely the ossicles will move. That is one of the ossicle is stapedis. So whenever this stapedis is moving, that will disturb this distended saccule, and saccule is mainly important for maintaining the posture and balance. And whenever the saccule is distended and it is getting irritated, surely it will lead to vertigo. Okay. So this is called as Tullio's phenomenon. So how we are going to find out? There are large number of tests to for the diagnosis. So here the main diagnostic test I am sharing it with you. The diagnostic test is electrocochleography. Electro. There are a lot of other tests, but we are going only with the specific test which is more important for this condition. That is electrocochleography. So this is all regarding the Meniere's disease. So let's move further to the next condition, acoustic neuroma or vestibular schwannoma. Acoustic neuroma or vestibular schwannoma. So now, let's see what it is. With the name neuroma, it is indicating some type of tumor, and acoustic or vestibular is indicating something related to the vestibular nerve. So let's see. So here it is none other than the benign slow growing tumor. Benign slow growing tumor which arises from neurilemmal sheath. That covering of the neurilemmal sheath. It arises from the neurilemmal sheath, mainly of the vestibular nerve. So in case of vestibular nerve, most commonly inferior vestibular nerve is affected, okay, than the superior vestibular nerve. Okay. So next. So now we are knowing what it is. Benign slow growing tumor arising from the neurilemmal sheath, that is covering of the nerve, and most commonly it arises from the inferior vestibular nerve. So next MCQ related to it is the most common tumor of all CP angle tumors. CPA angle. So cerebropontine angle tumors. So here acoustic neuroma is the most common one, and most commonly it occurs unilateral. Unilateral in how many cases? 90% of cases it occurs unilateral. If it is bilateral, what it is indicating? If it is bilateral, then we have to think regarding neurofibromatosis type 2. So in case of neurofibromatosis type 2, the acoustic neuroma is bilateral and it is also a diagnostic sign. Okay. So that is more important related to the bilaterality and another neurofibromatosis type 2 disease. And here the earlier symptom is unilateral sensory neural deafness. Sensory neural deafness with tinnitus. So these were all the common clinical presentation of the disease. So this is all regarding the acoustic neuroma. A few more points. So here we can get Hitzelberg sign, which we discussed while discussing regarding the anatomy of ear. Hitzelberger sign, I told you facial nerve supplies the posterior wall of external auditory canal. So whenever there is problem or because of facial nerve involvement, there will be reduction in the sensation in posterior wall of external auditory canal. So this is it. So in case of Hitzelberger sign, there will be reduction in the sensation in the posterior wall of external auditory canal. And the golden standard, how we are going to diagnose the condition, that is also more important. Here the golden standard method to diagnose the acoustic neuroma is MRI. Okay, MRI with contrast can be chosen to identify the acoustic neuroma. So this is all regarding the acoustic neuroma. Let's move on with the next condition, glomus jugulare or tympanicum tumors. So first, let's see the other name of glomus jugular. They were chemodectomas or non-chromaffin paragangliomas. So simple. This is also called as chemodectomas or non-chromaffin paragangliomas, and these were known to be the most common benign neoplasm of middle ear. Most common benign neoplasm of middle ear is glomus jugular or tympanicum tumors. And here the most common site in the middle ear is hypotympanum. So in case of middle ear, we know middle ear cavity, that is tympanic cavity. We have three tympanums, epitympanum, mesotympanum and hypotympanum, and this glomus jugulare arises from hypotympanum. Okay, and here I can correlate a sign related to this condition, that is rising sun. On otoscopy, on otoscopic examination, we can see the rise of tumor from the floor of the middle ear cavity, that is hypotympanum, which can be called as rising sun on otoscopy. So this is how we can correlate. And histologically, there is a named condition. So histologically, if we see, so there will be cluster of cheek cells that can be called as Zellballen. Okay, Zellballen. That is, I'll write here, clusters of cheek cells are called as Zellballen. Okay. Then comes rule of 10 related to this jugular. First 10% familial, then 10% multicentric, then comes 10% functional. Okay, and whenever it is becoming functional, it secretes catecholamines. So this you have to remember. It is arising from the ear, but as already told, it is a non-chromaffin paraganglionoma, so it will secrete the catecholamine. So these are all the things related to it, and few more signs representing this condition. So before that, I'm just repeating it. Also known as chemodactomas and non-chromaffin paragangliomas, most common benign neoplasm of middle ear. Most common site in the middle ear is hypotympanum, which can be called as rising sun on otoscopy. And on histologically, the cluster of teeth cells were called as Zell-Wallin. And rule of 10, 10% familial, multicentric, and functional. Functional means it may secrete catecholamines. And let's see here few signs related to this glomus tumors. First is brown sign, brown or pulsation sign. So what it is? So whenever we are applying pressure on the external canal, so external ear cavity, if we are applying pressure, what we can see, we can use here the pneumatic ear speculum. We cannot apply pressure directly, so here we can use this particular speculum. Pressure on external canal. There we can see a mass and blanching. Okay. So whenever we are pressing, there will be a blanch, that is stoppage of blood supply. That time we can see the mass, which is also called as brown or pulsation sign. Then comes aquino sign. So here what happens whenever we are putting pressure on the carotid, that is whenever there is any carotid compression. Whenever there is carotid compression, there will be decreased pulsation. Whenever there is carotid compression, there will be decreased pulsation. And already we had discussed regarding the rising sun on otoscopy. Rising sun on otoscopy. So this is all regarding the glomus tumors. And almost one more point. In case of MRI, we can see salt and pepper appearance. Salt and pepper appearance. So this is all regarding the diseases of inner ear. We had discussed regarding the Meniere's disease, then acoustic neuroma and glomus jugulare. So let's continue with the next video. Thank you so much. Happy learning with us.